Hello everyone. On this lesson I will talk about understanding digital workflow. The order of this lesson would be like this, and I will talk about workflows for digital dentistry first. I'd like to show you how I utilize digital devices in my clinic first. As most of you do in your clinic on a daily basis, so do I. Scanning, 3D printing for provisionals. When you acquire intraoral scan data before and after tooth preparation, you can quickly and easily design provisional teeth. At the digital dentistry, with this technology, we acquire the data from intraoral scanners and automatically design the restoration and make a fine touch on the design, and we can print out the models and provisions. A certain company manufactures, a certain company manufactures 3D printers which produces outcomes within 15 minutes. So if you have this one, scanning, provisionalization, all can be done in a half hour. Even with a complicated cases such as a retrofit for RPD, you can minimize error and reduce the time for adjustment by this sequence. So I met the patient who needed to replace survey restoration because of the secondary caries. So I removed the restoration, and I made a preparation on that abutment teeth, and I scanned the data at the second time. So after that, I designed the provisional restoration of the cast software, and I print it out with a rapid machine. Ordinary, after I deliver the provisional restoration, I need to modify and adjust it into old partial denture, and it takes significant time. But with this technology, I experienced the time consumed reduced very much. So I didn't adjust the restoration much, and I could easily finish the treatment because of this technology. The second approach, as you know, is model-free zirconia crown. I have conducted a clinical study of model-free zirconia crown made with a different intraoral scanners, and reported that both scanners are sufficient for clinical use. I'm going to skip the detail about this because most of you are familiar with this concept, but briefly, intraoral scanner is all the way through enough to go for simple treatment. So I compared Korean-made i500 intraoral scanners and Denmark-made Trios 3 intraoral scanners. Both intraoral scanners yielded a crown that would fit well on the patient's mouth. The marginal accuracy was around 40 to 50, and it is below the reference value, which is 130 microns. In addition to the 3D printed working model for intraoral scan data, the gold crowns are also produced by the lost wax technique after the 3D printing it into castable resin. If you want to use casting method, 3D printed crown can be burned out for the lost wax technique. My clinical study on accuracy has shown that the marginal fit is sufficient for clinical applications. As you can see from the naked eye, the fit of the restoration and the printed model is excellent, and it is not insufficient for the clinical application. Although the performance of the intraoral scanner has improved dramatically, I used the model scanner and semi-adjustable articulator for the broad area of occlusal reconstruction over the complete arch. The set values for the articulator can be entered into the virtual articulator of the CAD softwares to perform the same operation digitally in the lateral check bites. I test the provisional restoration with optimal occlusion in the patient's mouth. The shape of the provisionals is accurately duplicated by double scanning the provisionals and abutment teeth. I call it as digital technology, because digital concept and analog concept is combined together. At the Department of Orthodontics, I teach residents to diagnose and treat their patients digitally. They record the patient's jaw movements with mandibular motion recorder and use the virtual articulator to perform the diagnostic workshops. We check the aesthetic aspect of the diagnostic workshop through the integrated facial scan. If the occlusal plane is uneven, it is flattened with a virtual occlusal plane device. The design result is milled into the wax and attached to the articulator mounted models for verification. They also design provisional dentures on CAD software and manufacture it with a 3D printer or milling machine. 3D printing technology can enhance the effect of dental education. We can print out the real patient's model into 3D printed material. Dental students are very nervous when they first prepare the tooth for the crown. If I provide them with the 3D printed patient's model that will actually be treated, the material of the same feel as cutting the actual tooth, the students can practice on the same dental chair that they will treat before the patient's visits. It is a very effective training. This clone dental arch is designed from intraoral scan data and 3D printed. The base of this clone is compatible with the mannequin, which can be seated on the dental unit chair. The same education applies to students ahead of the extraction of impacted third molar. If the student practice by deleting his or her patient's tooth to be extracted in advance, you can treat it calmly without embarrassment during the actual surgery. Let's get into the further complicated cases. Of course, we can cast even RPD metal framework by casting if you have 3D printed metal framework design. Even though the final outcome was too big. My research reveals that it's clinically acceptable. I teach my residents to design his or her own partial denture framework on the software. Let's apply digital method on the complete denture. It can assist conventional way by fabricating the components of traditional method, such as individual tray. We can acquire intraoral scan data and utilize this data to design individual tray. After that, we can print out into actual tray. We can make a physical impression with these components fabricated with digital technology. These days, the discrepancy between virtual planning and manufactured denture is decreasing. Complete denture per se can be directly milled. Some people might think that the 3D printed denture can be useful. However, strength is still not enough. Denture produced by milling is way much stronger than 3D printed one. I will talk about it at the later lessons. Intraoral scanner helps me to solve the problem, and I could make a provisional denture to the patient who have had a severe gag reflex. In this case, the intraoral scan data was modeled by 3D printing to make provisional dentures with wire clasps on the model. The tooth to be extracted were deleted on the dental cat and printed out. Dentures were fabricated in a conventional manner. There is also a way to mill flexible materials such as valplast material directly, and I think there will be a chance to introduce them on the later lessons. I can also acquire digital impression without extracting the tooth that could be extracted at any moment during the impression procedure. So there is another tip. When the patient occludes, the tooth can be deviated like this. So when you acquire a digital impression, we can easily acquire the data without extracting the teeth. And when we are acquiring a lateral bite registration, I recommend that we can capture the bite scan other than this area, because this is mobile area, so it can interfere the exact procedure. One patient with a husky voice visited the clinic, and he wanted to get his normal voice back. He has undergone cancer surgery, and his uvula has to be resected. With the help of optical impression device, I could get an image of structures deep in the nose and throat. I designed speech aid device by 3D printing, 3D modeling, and printed it out. I could get his voice back again. Can we do more? We have a meta framework from the previous slide, denture teeth from the company. What do we need for completing this case? Yes, we need a flask. We fabricated it by 3D printing, and then we processed it, built it, and finished it up. I could digitally manufacture denture with metal framework easily with digital technologies. We can print out metal framework with metal 3D printer, and we can design the patient's denture by utilizing virtual patient. In South Korea, it is necessary to make a metal framework embedded denture with a heat curing resin in order to receive national health insurance. I'm developing digital denture manufacturing technology for this unique environment at my hospital. The process of flasking and curing dentures traditionally is difficult, and we might get inaccurate, for example, high-end tissue impinging denture, depending on the technician's experience. However, there are many benefits to automating this process with milling and 3D printing. As you can see from the pictures, the unit of error is several microns. If the impression is correct, it will be a very well-fitting denture that requires no adjustment. If the patient wants a ceramic occlusal surface, the denture can be customized with zirconia teeth, and the patient's satisfaction is quite high. The retention of the denture is strong enough. You can feel the stability and retention of denture through the video and the sound. I'm asking the patient if the occlusion is the same on the right and left side. I'm also asking whether it is painful when he bites firmly with the new denture in the mouth. The occlusion of zirconia teeth was in the harmonious state, and there was no need to adjust the tissue surface. He said he was satisfied with his digitally manufactured zirconia occlusion denture. For the auto-transplantation, the third molar teeth were extracted from the CT data, and the 3D printing was done to prepare a recipient site before extracting the wisdom tooth. If we can get the 3D image of hard tissue prior to the surgery, the operation will become very easy, and the result also would be excellent because of the prepared accurate template teeth. The patient with severe asymmetry from inadequate reconstruction after tumor removal came into the clinic. Three-dimensional images for skull were extracted by 3D segmentation software, and left mandible body, ramus, and joint were 3D modeled. Oral surgeon, who is one of my friends, and I could design and implant new artificial mandible using the segmentation and modeling process. Also, two implants in the wrong position could be surgically transferred with the help of template designed on the 3D data extracted from CT. The location of the placed implant is poor. The treatment result will be unaesthetic like 3D image on this photo. The appliance for repositioning the bone fragment with implants was designed through 3D modeling and manufactured by 3D printing. This is the photo of designed appliance. Two implants were removed, and two implants were moved into a good location. For those who are interested in my many digital usages above, please feel free to download my research articles. I did some research on the accuracy of intraoral scanner, such as accuracy of complete arch scan, learning curve, and accuracy of model-free restoration, and new digital assessment technology techniques for clinical study, and resolution and expression detail of digital impression body. Also, I can introduce you further on the lessons later about a IT scan and bracket and orthodontic treatment accuracy. You can also review the research about 3D printing performance evaluation, such as implant surgical guides and artificial teeth that is printed with 3D printers, wear resistance and fracture strength and flexural strength of 3D printed provisional teeth, metal framework. Also, you can refer to the how to make a virtual patient and its clinical evidence from those URLs. Yes, it is end of this lesson. Thank you.